Today, John is going to give us a presentation on doing everything palliative care and cardiac arrest. So this should be a great presentation. So I'll pass it over to you.
Thank you so much. Uh, wouldn't be a lecture without some technical difficulties. So thank you all for joining. Yeah, thanks for having me again for this one of my favorite talks to give. For those of you I haven't yet met, I'm John Abraham. I'm one of the faculty over at the Corewell Health MSU Fellowship. I have an emergency medicine background, so cardiac arrest, cardiogenic shock, resuscitation is part of my background and caring for sick patients in that manner. And so this is an area of interest of mine, and I'm going to share with you how this topic relates to your work. So I have nothing to disclose. Uh, and just to summarize our learning objectives today, we are here to understand the current state of cardiac arrest care and the implications for our work and our patient population. I'm hoping that we can leave this talk having a better understanding of advanced heart failure interventions, particularly ECMO and its sort of permutations, depending on where you work. If you were practicing in a hospital setting or a tertiary quaternary center, ECMO may be part of things that you encounter on a daily basis. And also we're hoping to be able to describe, how ECMO overlaps with palliative care and our work. So we start with a case. This is a real case from my fellowship. I did fellowship at Henry Ford in Detroit. So a 63-year-old patient with a female with pulmonary sarcoidosis was hospitalized for basically acute hypoxic respiratory failure. Unfortunately, she decompensated in the hospital, had a cardiac arrest, and was able to be successfully resuscitated, but they had difficulty maintaining perfusion, oxygenation, and so in profound cardiogenic shock, and was cannulated for VA ECMO, and was able to be stabilized in that manner, including extubating her. She was intubated during the code, and she remains on the ECMO circuit while she's awaiting lung transplant. So there's a lot of sort of technical jargon in there. And I think by the end of this talk, you're going to understand exactly what's going on. But for our fellows, people who have maybe heard this talk before, who may already know the outcome, I want the fellows, the current fellows, to start thinking about what are the sort of palliative considerations. If you were coming to the bedside, what questions, what might you have in terms of this patient's needs? So I think we need to get a lay of the land. It's like approaching goals of care. You want to know the big picture. Where are we coming from? And how did we get here? So I think it's important to know, from bird's eye view, what is the state of cardiac arrest care in the US? So for years, decades, we had no way of knowing. People just died at home or they died in the hospital and filled out a death certificate. We didn't really have a good understanding of the data behind these outcomes until some smart folks at Emory and the Institute of Medicine thought it was a good idea to put together a database to track these patients, track these outcomes, these interventions. So in 2004, over 20 years ago, which is crazy, they established the CARES database, the Cardiac Arrest Registry, to enhance survival. And in the first year, they logged 600 cases of out-of-hospital cardiac arrest. And as of a couple of years ago, so flash forward to 2022, the last time I pulled this data, there was over 2,800 cases of out-of-hospital cardiac arrest weekly. So 600 annually to 2,800 weekly in this database. So it's, as you can, I guess, ascertain, this is a massive database. And it is sort of a state subscribed model. So you have different states submitting their own data. And Michigan is one of these states that participates in the CARES database. And so we have our own sort of initiative and own registry, and we submit our data annually or semi-annually to the national database. Our I guess, organization or initiative is the Save MI Heart. You can go on the website, you can pull data if you are into that sort of thing. And they work in not only just data recording, but community education, that sort of thing. So let's dive into the numbers a little bit more. So on the left here of your screen, we have sort of totaled the number of cardiac arrest cases that were on record for this for in the CARES database. So from 2013 to 2022, they recorded 876,000 cases of recorded cardiac arrest out of hospital only. 46% of these patients had recorded bystander CPR. Overall survival rate was not, a little over 9%. So a little, slightly fewer than 1 in 10 people survived in this database. And survival is recorded as being able to be discharged from the hospital. In hospital cardiac arrest, if you're going to have a cardiac arrest, do it in the hospital. You have a much better chance of survival. 24, almost 25% of patients recorded survived in hospital cardiac arrest. So this is a very busy slide with tiny font. I don't expect any of you to read this, but this is sort of a survival report. What were the, it dives into not just the bystander CPR, no bystander CPR. Did you have a code in front of a paramedic? Did you get shocked by an AED? All of these things are recorded. They even have a column on hypothermia. We used to, not too long ago, everybody who had survived a cardiac arrest, a VFib arrest, was therapeutically cooled. And I don't think that's just as a neuroprotective intervention to save people from anoxic brain injuries. You heard about those cases way back in the day of the little kid fall through the ice and drowned, and because they were cooled, they had a perfect neurologic outcome when they fished them out of the ice. I don't know that the data has borne out for this patient population, so you don't see that as commonly anymore. But so this is blown up from that big table, and this is a pretty profound piece of data. So of those patients, right, we were talking, that was a national statistic. So 9.2% or whatever of people who experience an out-of-hospital cardiac arrest with bystander CPR survived discharge from the hospital. So this is our Michigan data of 9,000 patients in a similar situation. And of the people who survived the hospitalization, well, what happened to those people? So this is survive. So this table says 8.1%, so a little bit worse than the national average, survived to hospital discharge, but 6.5% of the total patients discharged from the hospital with what's categorized as CPC 1 or 2. And the CPC is basically your level of neurologic disability. And so a CPC 1 or 2, a CPC 1 is basically you have a minimal, deficits, you have minimal neurologic injury. A 2 is basically like you can interact with the world, you can, maybe work a job, but not the job that you had before. You have some executive function. You may have, hemiparesis. You may have, a notable disability, and which means that, only 6.5, these are the best cases. So 6.5% of all comers had some, some neurological disability. Obviously, CPC3 is like pretty significant disability. Um, uh, and so these are pretty staggering numbers. We think about code status discussions, and some people like to bring data. This is, X number of people who go through this intervention have this sort of outcome. I think this is this is pretty interesting information. I don't know uh, which conversation would warrant bringing in statistics like this, but I don't know. It's worthy of talking about that. The majority of people who survive this sort of thing have a pretty significant neurologic disability afterwards. Um, this is, we talk about code status, we talk about advanced directives. We've all heard of the DNR tattooed on the chest. I saw this on the internet, and I thought this was kind of interesting. This person tattooed basically their condensed living will, including witness signatures, which is my favorite part. Tattooing witness signatures on your body was pretty wild. Um, so it's not all bleak. Things work in terms of cardiac arrest interventions. Well, what works? Early CPR, defibrillation, right? Those people who got bystander CPR made it to the hospital. People without out of hospital CPR did worse. Early access to defibrillation. It's These are the American Heart Association recommendations. It's a class 1 recommendation. The evidence strongly supports early access to defibrillations. This is why AEDs are in airports or in McDonald's. They're at the, trampoline park where you may see me with my kids. This is a life-saving intervention, and it is only the quote is the only rhythm-specific therapy proven to increase survival to hospital discharge is defibrillation of ventricular fibrillation or pulseless ventricular tachycardia. So those two dysrhythmias, like electricity, or dislike electricity, you get them back into a stable rhythm by shocking. So if you see somebody go down at the airport, remember your ACLS or BLS, and part of it is, pointing to somebody and said, "Hey, you go get the AED," because that'll save the life of the patient, or is the best chance of saving their life. Um, so what else works? Epinephrine. If you trained in a hospital, most of us, physicians or providers or, people with nursing backgrounds, we may have been involved in a code at some point, and you may have asked for epinephrine or heard people asking for an epinephrine. It's a cycle. It's part of the ACLS algorithm. And so epinephrine works, right? Well, kind of. It's a whereas defibrillation is a class 1 recommendation. The American Heart Association places this as a class 2B recommendation. It's like evidence mostly supports it. And their language is, well, standard dose epi, 1 milligram every 3 to 5 minutes may be reasonable for patients in cardiac arrest. Use your own judgment. I don't know. The language is not the most glowing, but uh, and we'll see a little bit why that is. So why are we so cagey on the data? Well, epinephrine was the data to support it comes from the 1960s, and it was they were utilized studies on animal models. So this is a sad dog because this is a sad study, but they induced asphyxia on 7 groups of 10 beagles. So RIP. Thank you for your service. For us dog lovers out there, it's a tough beat, but they induced asphyxia on these poor beagles, and 10 out of 10 beagles who received ventilation, compressions, and epinephrine achieved ROS. So all the dogs survived a little while, but epinephrine was part of that recipe. flash forward to a couple of years ago, where are we at now? We were some smart people decided to take another look at the data around epinephrine, and there was a randomized controlled trials, this Paramedic 2 study. And their conclusion was in adults with out-of-hospital cardiac arrest, using epinephrine resulted in a significantly higher rate of 30-day survival than the use of placebo, but there was no significant between group differences in the rate of a favorable neurologic outcome because more survived, but they had severe neurologic impairment in the epinephrine group. So it's like, sweet, right? We've kept people alive, but they're going to have a tough time going forward. So I mean, but again, right? We don't want to project our own goals and values on our patients. Maybe surviving with some neurologic deficit is okay, right? Who's to say? Um, so not great, right? Like the data is sort of bleak, right? Um, but there's other things out there. Okay, these aren't the only interventions that we have at our disposal. And before we dive into those, I think it's important to remember our anatomy and physiology, and cartoons help us do that, right? So this is a normal human circuit of basically cardiac output. We have at the top, these are all acronyms, but obviously the right atrium, right ventricle, blood's pumping from the right ventricle to the lungs, where the deoxygenated blood gets oxygenated. The oxygenated blood goes to the left atrium, the left ventricle, to the aorta, and then the aorta pumps the oxygenated blood to the tissues. Then they do their thing, and the deoxygenated blood goes back through the IVC and the SVC, and we start it all over again. Thumbs up, thumbs down. So any break in this chain, right, we're going to have problems. We're going to have major problems. And at several points in this circle, we can intervene. We can do things, and things that help. So flashback to 1952 in Detroit, Michigan. The major headline was "Robot Heart Keeps Man Alive Here." So some engineers and physicians in Detroit basically did a cardiac bypass with this, V6 engine from a Pontiac or something. It's pretty rudimentary if you've seen what we've got going now, but it was a pretty landmark thing. I mean, the surgeons were probably still smoking in the OR, while they were putting this thing in, but like, this was a major step forward in keeping very sick people alive. So basically heart bypass surgery. The Michigan Heart, they called it. You may work in a center that has implants LVADs or cares for LVAD patients, or you may care for LVAD patients in a hospice setting. So an LVAD is for people who have decreased cardiac output for whatever reason. They have systolic heart failure or cardiogenic shock, and they live in a shock state. And basically, it is a heart pump. Basically, the heart imagine the circuit again. So the heart is having difficulty pumping the oxygenated blood to the rest of the body just because of poor squeeze. And an LVAD, they've gotten as they have sort of advanced in technology, they've gotten smaller and more discreet. But basically, it's a pump. The pump is inside the body. There's a power cord, drive line, basically that exits the skin and plugs into an external power source. So you can plug it into the wall, or most people, when they're on the go, they have some sort of battery pack in a purse or a pocket or a pouch. And it is sometimes a bridge to transplantation, meaning it's a temporary therapy, or it's a destination therapy. If someone is not a transplant candidate, this is we at Corewell Health do pre-LVAD implantation, like goals of care conversations. Uh, in fact, some it may be a JCO mandate that people who are undergoing this intervention or heart transplant evaluation have a palliative care evaluation or consult, because it's a big deal. In Michigan, in the Midwest, it's a big deal because one of the things that you have to tell people is that's hard to swallow, is that they cannot submerge in water basically ever again. At least with the current technology, you can't jump in a lake with an LVAD. And so people, have something to say about that. Water and lake life is a big part of a lot of people's quality of life, and so it's a tough pill to swallow. But so is living with systolic heart failure, I guess. Um, I'm jumping through a couple of uh, I guess devices, interventions that I would hear as a resident and a fellow. I'm like, okay, I get that that is something that is helping somebody in heart failure, but what exactly is it? And so an Impella is another device. It's actually the world's smallest heart pump. So another patient example, somebody who's struggling in the ICU, most likely, or cardiac ICU. Uh, Continues to struggle with cardiac output. And this little device is fished through the femoral artery, snaked up through the body into the aorta, and lives in the left ventricle, where it has an intake valve and an output valve. So the intake is in the ventricle, the output is in the aorta, and it's basically, slurping the blood out of the ventricle and into the aorta, giving it more sort of afterload. So increasing cardiac output just by, plumbing. So it's an internal pump, not something you go home with. Uh, Another one that I would hear about and like, what is this thing? The intra-aortic balloon pump. So, this is not for increasing, well, it does help in increasing cardiac output, but it does so differently. So it's a balloon that lives in the aorta, and inflates and deflates depending on if we're in diastole or systole. So diastole, remember, like the chambers are filling up with the ventricles are filling up with blood. Systole is a contraction of the ventricles, eject blood into the systemic circulation, or pump the right ventricle, pumping into the lungs. But you may or may not remember from your cardiac physiology that the coronary arteries are perfused in diastole. So when the ventricles are filling up with blood, not squishing it out, that's when the coronary arteries are feeding the heart with blood. And so if your cardiac output is down, it's sort of like it can be a snowball effect. So the coronary arteries with that decreased pressure are getting less blood flow. And so what happens with the balloon pump is in diastole, it inflates, sort of blocking forward flow, blood to the kidneys, essentially, because you can see the arch of the aorta. This is in the sort of down the southbound blood. And so what it does is it sort of backflows into the coronary arteries, increases cardiac perfusion, and the heart pumps better when it has, more oxygen. So that's how the balloon pump works. And ECMO. This is sort of the main focus of this talk. You may remember a couple slides ago we talked a little bit about the case of a patient I cared for who had that cardiac arrest and was placed on VA ECMO. So VA ECMO it replaces the heart and lungs. It's a heart and lung bypass. So your lungs aren't working great. In the case of this patient, she had pulmonary sarcoidosis. So, fibrotic, nasty lungs, not working so great. So difficulty with, achieving oxygenation in her, alveolar beds. Um, uh, but also she had cardiogenic shock on top of it. So difficulty with forward flow. So VA ECMO gives you forward flow and oxygenates the blood, whereas VV is basically just a lung bypass. So this was what you may have seen in sick COVID patients or patients who have cystic fibrosis who are awaiting lung transplant might be on VV ECMO. VV ECMO, if you see somebody walking around the cardiac ICU with their ECMO, with their gazillion pumps, but they're working with PT, they're probably on VV ECMO. Like the VA ECMO folks are tend to be sicker. So what is ECMO? Extracorporeal membrane oxygenation. So VA is veno-arterial. ECMO VV is veno-veno. So this is your VA you're reaching for in the cardiac arrest, primary cardiac failure, cardiogenic shock, pulmonary hypertension. And you need a heart transplant like yesterday. You might be on VA ECMO. It's like a pretty emergent crash kind of thing in many cases. Whereas ECMO is pulmonary failure, so ARDS, like those sick COVID patients, pneumonitis, people who are waiting lung transplant, like I said, or like do they have an airway disaster, like there is some trauma and they've transected their trachea or something gnarly. It's just there's some you can't ventilate them the old-fashioned way. Um, so different cases, different contexts, different clinical indications. So I highlight the VA ECMO because that was what my patient had. And this is maybe what you see if you're walking by a room and they're cannulating someone for ECMO. It's a sterile procedure. It's kind of bloody. We were dealing with the biggest vessels in the body. So but it is a sterile procedure. This is obviously like a crash ECMO. You see people on their knees. This is not super typical from what you might see. And I'll tell you a little bit more about the story behind that picture in a slide here. But the photo on the right is more sort of representative. Obviously, the tech changes all the time. It may not look exactly like this, but you got if you ever want to see the difference between oxygenated blood and deoxygenated blood, like look at the ECMO circuit because that tubing is clear. And it's a pretty distinct color change. So what's going on in that box? This is a busy slide. It gives me a headache, so I'm not going to expect you to look. But it is everybody's favorite semi-permeable membrane. So it is some matrix, some membrane. The blood washes over this matrix, this membrane. Oxygen is delivered to the blood. Carbon dioxide is slurped out of the blood, and it goes around and around. And so it's approximating the normal human physiologic circuit, but obviously it doesn't work as well as what nature gave you. So the injured VA circuit on ECMO, you may remember a couple slides back, our cartoon, our unhappy face, our happy face. Well, it bypasses the unhappy circuit and sort of maintains the happy circuit with technology. So you got your pump, your oxygenator, cannula goes into the femoral artery. So it's a little bit backwards, like the VA ECMO. You're cannulating the femoral artery, so you're kind of pushing against the normal cardiac output, which seems counterintuitive, right? So you're pushing blood to the heart through the arterial system, and you may remember, right? Blood returns to the heart through the IVC and the SVC, but we're pushing blood to the heart with the through the artery, the femoral artery, the aorta, basically. Well, how would that work, right? Why are we, you know, going in through the exit? Well, the heart is shot, right? Like that thought process, or that sort of that counterintuitive question really only comes to play with a heart that works, right? This heart is essentially non-functioning, and so it's just a part of the circuit. And so the forward flow, which is significant through the femoral artery, is enough to get blood to the oxygenated blood to the brain. So um, uh, compensating for a heart that's not working well. So why am I like harping on ECMO? Like, who cares, right? Well, we talked about epinephrine, we talked about shocking people out of shockable rhythms. Well, ECMO is exciting for because the numbers are pretty pathetic for heart survival. Still, like it's 2025, our numbers still kind of stink for surviving cardiac arrest. Um, until ECMO came along and studies started coming out, and several studies started saying, well, the survival rates might be better with ECMO, right? They might be better if we can get uh, people on ECMO circuits, VA ECMO in particular, for cardiac arrest patients, they may do better, which is not, I guess, outside the realm of possibility, right? Uh, we're talking about neurologic outcomes and being able to survive this like this global hypoperfused state, this anoxic state, um, which is, causing all of this morbidity, mortality. And the sooner that we can get them perfused, the better, right? So ECMO studies started coming out, and people opened their eyes. Like some of these studies were like amazing, right? 55% favorable outcomes. Like these numbers are tremendous. Obviously, some are more modest, like 4%. Okay, well, that's kind of a little bit worse than what we already have. But it's enough to, like, everybody's favorite line in a research study. It's like, recommend more research on the subject, which is their findings, right? So more research. So this is the same picture or a different angle, the same picture from a couple of slides ago. Why these skilled uh, providers are placing ECMO on their knees. Well, because this is a subway in Paris, the metro, I guess. I haven't been to Paris in a while, but the so out of hospital ECMO cannulation is happening. So pre-hospital ECMO interventions has been implemented in several cities in the world, mostly in Europe. Um, and there's reasons for that. I think maybe some of these studies actually originated in Europe. And I think also it's sort of a logistics things. Like, there are cities where it is more conducive. They have rapid mobilization teams that can do this. And I think one of the barriers to the implementing this in the U.S. so far has been, the U.S. is spread out. It's hard. We don't have like condensed, concentrated cities. I mean, like if you look at Houston, Texas, for example, it's enormous. It's like the size of Connecticut. And so like implementing a citywide infrastructure like this, I think is a challenging thing to do anywhere. So, but this is something that we're seeing more and more of. And we may see more of it if as the sort of data continues to be collected. This is another photo at the Louvre. This is sorry for the grainy quality, but another example of the pre-hospital ECMO cannulation. And I like these guys on the side who have like the desk lamps. Like clearly they like raided somebody's office to give like OR lights. Uh, and you don't see anybody, breaking and stealing the family jewels, the crown jewels in the background, but might be a good time to do that. Uh, so like everything in medicine, especially the more invasive stuff, there are complications. So, whereas it's very exciting, this pre-hospital stuff. Well, we were talking about in-hospital mortality as well. And these patients are sick, right? You got to be very sick. Maybe one of the sickest patients in the hospital to get cannulated for ECMO. The mortality, not so great. In-hospital mortality is 63%. These people are super anticoagulated, uh, so they don't clot off their limbs. When you have different flow, you have stasis in certain areas, venostasis in certain areas. You're at risk of DVTs, PEs. So super anticoagulation, and clots don't just form in the body; they also form in the machine. And so keeping things nice and sort of thin and flowing is important. You can have mechanical failure. The circuit can go. There are filters in place that can clot and cause a problem. Limb ischemia. So we're cannulating the femoral artery. Okay. So like the leg getting ischemic is something, the leg getting compartment syndrome, the leg needing, its own surgical intervention. I mean, these are things that are happening. Um, well, your neurologic injury, so stroke, hemorrhagic stroke, embolic stroke, strokes can be a problem. And then, you have big cannulas, catheters going in places that they shouldn't. You have a risk of infection. And I mean, pain is a part of the deal as well. So our case continued. So the patient remained on VA ECMO for several weeks while she awaited lung transplant. So she was ECMO as a bridge to transplantation. During the fifth week of her hospitalization, she had a hemoglobin drop, and a CT scan found a large retroperitoneal hemorrhage. So spontaneous hemorrhage. It was not a traumatic thing. IR was consulted but unable to offer an intervention based on where it was. And unfortunately for our patient, due to the bleed, she was deemed to no longer be a candidate for lung transplant. Um, Unlike LVAD, ECMO is not a bridge. I mean, excuse me, ECMO, unlike LVADs, ECMO is not a destination therapy, never a destination therapy. You can't live on ECMO forever. And so it was informed, this sort of brutal news was shared with the patient and family, and ultimately it was decided to transition to comfort care to discontinue life-sustaining treatment. Just she was transitioned to comfort care with our help, and she died approximately 20 minutes later following ECMO discontinuation. So sad outcome. Definitely had palliative care needs. Well, before I move on to the next slide, another sort of complication or considerations, ECMO in palliative care patients. So this was not so when I was researching or doing, a literature lookup on like, how do I do comfort care transition in a ECMO patient on ECMO? We've done a lot of, in my fellowship, we did a lot of ventilator, withdrawals, discontinuation or extubations. So I had a better understanding of that, but I'm like, what do I do with the circuit? How does that work? How do I have to dose medications? And so I what I was able to find wasn't very much. In fact, one of the papers was written by Dr. Oz when he was like a cardiothoracic surgeon at Columbia. Um, which was interesting. It's actually a pretty good paper, but what I learned is that it has its own considerations when transitioning to when you're providing medications for comfort on VA ECMO. The circuit can sequester certain molecules, certain medications. So, like your patient who has cancer-related pain and they go to dialysis. You sometimes hear about, oh, my pain gets terrible during dialysis because basically it dialyzes the oxycodone out of my system. So ECMO is similar. There is some evidence to suggest that fentanyl is a good agent to choose because it's not as sequestered as readily on the circuit. But like I said before, more research is needed. So you could write the paper. Um, so there are, you know, medications or pharmacologic considerations in this patient population, but like, how do you approach goals of care in these patients? I mean, it's pretty, um, I like to say, what I don't really make decisions for patients, but my goal is that they make informed decisions with my help. Like I'm filling in gaps in their understanding, I'm making sure their questions are answered, and that they have a care plan that's in line with what's most important to them, right? Well, I can only do that when I have some understanding of what's going on, clinically with them, or I feel like I do a best job when I have as much understanding as I can. But how do I approach that with when sort of medical or sort of philosophical questions about death and dying are in flux, right? Like if your heart and lungs aren't working, um, but the machine's keeping you, pink and well perfused and oxygenated and you're mentating, like what we're kind of in between worlds, right? Like, how do we pronounce somebody who's died? It's like, well, we have our cardiac, cardiopulmonary exam, right? No heart tones, no spontaneous respirations. It's been 5 minutes. Okay, I think we can pronounce time of death, you know. Um, but well, what do we do when when there's no heart activity, there's no lung activity, but this machine is working for them? Um, Brain death is something different, right? But I mean, I had a patient in the cardiac ICU, a young man, unfortunately, who had a terrible cardiac arrest, and I think an associated neurologic injury. But I saw him for goals of care. He was on VA ECMO and his EKG was essentially flat. And I remember seeing his echocardiogram and his heart wasn't really pumping. So this guy's not waking up off sedation. His heart's not pumping. His lungs aren't really doing much either. Um, and I had to go to talk to family about what they want to do, and they're like, "Well, his numbers look great. What are you telling me?" And I'm like, I don't really know. It's complicated. It's still befuddling. And so you see my little picture from The Princess Bride, one of my favorites. This is Miracle Max saying there's a big difference between mostly dead and all dead. Mostly dead is slightly alive. So, thinking about that as we go into our goals of care conversations, like how do we define what we're seeing, what we're talking about, and how are we expecting our patients and their families to understand, to make informed choices about their care and their loved ones' care? It's pretty wild stuff. Um, so coming to the end of my chat, this was a almost 1 month ago to the day. We had a big loss in Michigan. The father of ECMO, Dr. Robert Bartlett, died at 86 years old. He was a professor at Michigan Medicine, a well loved physician in the community, and is widely credited as the father of ECMO. And so it is a fitting tribute to honor his legacy and talk about, what he has, contributed to this area of care. And I will conclude there. I welcome any questions, comments. I haven't had a chance to look at the chat if there's anything in there, but the floor is yours. Thank you so much.
Speak up. Okay, try that. And if that doesn't work, we can get closer. It's only a computer there.
I think if you shout, we can hear you.
Yeah.
No, so I had a question just about the kind of the wide range we had for survival in out of hospital cardiac arrest for those who are getting ECMO. Are there like other prognostic indicators that we can look at to maybe determine kind of which end of the spectrum someone is falling on so we can have a better understanding of their chances and then um, have a more informed discussion.
Yeah. Um, that wide range is pulling from several studies, a dozen studies or something. And so um, there may be a meta-analysis out there that sort of summarizes, gives you sort of ballpark figures. I I rarely think that ECMO will be part of like, a pre-ECMO goals of care conversation may or may not be part of, I guess, our immediate role. It's one of those sort of it's not it's like a pre-defibrillation goals of care conversation. Like if you need it now kind of thing. And so um uh but I think those numbers are important as you're approaching somebody who may be already on the circuit. What is their outcome going to be? I mean, I think an important number to take away is that still, despite all of these innovations, 63% of patients on VA ECMO don't survive their hospitalization, which is, significant, right? So, um, just approaching these patient conversations with that background knowledge. Now, um, it's not like the out of hospital cardiac arrest CPR that I think is the only 6%, 6.5% or whatever, and of those patients are going to leave the hospital without a profound neurologic disability. Like that data, I think, is going to be much more useful in your goals of care conversations. Whereas ECMO, it's I think while it's important to know about, it's important to think about. I think it has the potential to be more prevalent as time goes on. I think that broad range of survival statistics is just an indication of what it can is more there to show you what it can be or why people are interested in it. Because you see numbers like, well, we're going from 9 out of 10 people die pre-hospital or do not survive their hospitalization after experiencing cardiac arrest. But now you're telling me 55% might because ECMO was involved. Like you have my attention, right? Even if it's double, right? We save one extra person in 10 with ECMO. Like that's very exciting. And so the more research may build the case, may sort of detract from that excitement, but we're starting off so poorly in terms of outcomes. I think any sort of opportunity for improvement is interesting. Is going to be exciting for the community. But good
I'm just
question.
trying to wrap my head around how I'm going to approach the patient in 10 minutes when I walk into the room and they're on ECMO and they've got this plethora of comorbidities sitting in front of us. And in the case that you presented, it sounds like she's not going to I mean, she ultimately died and that was the decision. So the way I would imagine this is presented is you have no heart, you have no lungs, and you have no hope. And so here we are. I mean,
Yeah.
that's not going to be how I present it, but that's essentially the data I have in front of me.
Mm-hmm.
Now that's going to vary from patient to patient. And I would imagine that's kind of what I'm looking for, is how do I accumulate the information I need to present a reasonable picture of what to expect. And
And I'd even piggyback on Bruce's question. What did you tell that guy that was the last patient you presented? What did you tell that family? And I mean, I know it's hard, but what
Yeah.
ended up happening? Yeah.
Um, I, I have, as I've, I guess, gotten older or gotten more experience or sort of more comfortable in these, I guess, difficult conversations, I'm more comfortable saying I don't know. And I articulate the ambiguity. I mean, I remember the family very well. I said, I there's no words that I have that can make this make sense. Basically, I'm like, but he's the person that you knew is not coming back. It's not so it wasn't like a medical summary as much as just sort of like a summary of the circumstance. Um, uh, because I didn't really have any other frame of reference, it was really tricky, but thought-provoking, right? And you often well, unfortunately, we are approaching some of these goals of care conversations where there is, the goals of care are almost like a misnomer, right? Like, what is your goal when you have no options, right? Or you have such limited options. It's like, you've got one thing on the menu essentially. So it's like, why ask them what they want to eat? It feels rough, right? These are tough conversations to have.
well, in this case, and this, I've not seen anybody on ECMO, strangely enough, but if, when they're on ECMO, are they conscious? I mean,
Yeah, so a lot of people are intubated and sedated, their lungs weren't working, and that's sort of step one of addressing their hypoxia. But so my first patient that I cited at Henry Ford, the lady who was awaiting lung transplant, she actually was extubated and was cognizant. The gentleman in the second case was remained on the vent and was not responsive, but he was off of sedation, raising concerns for what was going on in his brain. But yeah, it was. From the docs I was working with, they're saying, yeah, it's more rare, for people to be on VA ECMO and not be on a ventilator as well. But in this case, she was talking to me.
so you could have that conversation that
Correct. She participated in that
it's
conversation.
not destination therapy, and when we withdraw.
Yeah, that was a really, sad day. Yeah, absolutely.
Okay.
A good question. I see a hand.
Yeah,
Oh,
hand
go ahead.
raised. Leonard?
Yeah, I see a hand raised.
Oh yeah, I was just there's actually somebody who's really young on VA ECMO right now in the ICU that palliative care is consulted on. And he is awake and not on a ventilator in his early 20s. And the palliative care team is really struggling to just find the words and find the kind of support. It is futile care at this point. He will not be able to be decannulated. And he's just awake and processing his mortality. So I think it happened. It's super rare that it happens, but when you have these patients, they are very, it's a hard walk to walk with them because it's very intimate. It's very sad. And I don't know, not very many people get to process their impending, you know, death, and what that's like to be with people in those moments is, I don't know. The teams were struggling through it right now. So
Thank you for sharing that. Yeah, I mean, this is a special consideration One of my co-residents actually runs an ECMO program at a hospital in Pittsburgh, and he says they have had auto-triggered palliative consults for all VA ECMO patients, not VV ECMO, but all VA ECMO patients there get a palliative care consult, which I thought was really interesting. We don't have that at trigger at our institution yet, but I mean, as you shared, clearly there's a need, and we should know, we should know as much as possible about these types of patients to provide sensitive care.
Then, John, there is a question in chat. Nancy asks, is there a hard cutoff on how long someone can be on ECMO?
That I am not certain of. I mean, I can only share anecdotal evidence. When somebody is declared like futile care, right? That young man in the ICU who's on ECMO currently, like who is going to make the call to just shut up, like flip the switch, right? I mean, maybe he will, but it is extremely difficult, I mean, emotionally weighty. I mean, I don't know that many, CT surgeons, surgical ICU, physicians who are going to be chomping at the bit to say, hey, today's the day. We got to stop. What I have seen is sort of a waiting game for one of those complications that I listed in a prior slide to occur. What I have seen is that, the filter in this device, let me see if so this picture, in these boxes that are hooked up to the circuit, well, one of those is a filter that that is a disposable item, and so it needs to be changed, like a oil filter in your car, and it has a shelf life. And what I have seen is people say, well, we will keep it going until the filter dies, basically. Like when the circuit goes down, we're not putting it back on, kind of thing. So that might be a couple of weeks, basically, but it's tough. I haven't heard of a hard cutoff.